Good afternoon, everyone. Welcome to our webinar. My name is Gabriele Closerdo. I'm the Director of Science and Research at Myeloma Canada. Before we start our presentation today, I just wanted to, again, thank you for coming. Today's topic is going to be a myeloma research update. We're very lucky to have a great speaker and presenter with us, and a great doctor too. So before I introduce you to him, I just wanted to thank our sponsors. So thank you to Amgen, Binding Site, Bristol Myers Squibb, Janssen, Takeda, and Sanofi Genzyme for their support of our webinars. Without their support, it'd be extremely difficult to do them and to do as many as we do. All of our webinars, for those that don't know, are recorded. So they're recorded, and we put them on our YouTube channel. How do you access those recordings? You're going to get a lot of information today. So if you want to go over some things, maybe pause on a slide and really look at the data and try to figure things out. If you didn't understand it the first time, it's a good way to do that. So youtube.com, even on your phone or on your tablet, you go on the YouTube app. In the search bar, you put Myeloma Canada. One of the first links you'll see is the Myeloma Canada channel. You can subscribe, and once you subscribe, you could even click on the little bell. The little bell will basically tell you every time there's a new video that's uploaded to our channel. So that's a good way to stay up to date with the latest. You could also access that from our website, so myeloma.ca, onto the resources button up here. Once you click that, another menu will open. Click on educational videos, and that'll just send you off to the YouTube channel. Lastly, how do you ask questions? So during the presentation, don't hesitate. If a question comes to mind, type it in. The questions will come to me. I will, at the end of the presentation, ask our presenter to answer them. If you have a phone or a tablet or any other device, it's a very similar process. There's a little questions button. You type in your questions, you click the send button, and I'll get those questions at that point. So without further ado, I'd like to introduce you to our speaker today, Dr. Joseph Mikhael, who's Chief Medical Officer at the International Myeloma Foundation and Professor at TGen, which is the Translational Genomics Research Institute at City of Hope Cancer Center. He's also a consulting hematologist and director of Honor Health Research Institute and an adjunct professor at Arizona State University in Phoenix. So we're extremely privileged to have Dr. Mikhael with us today. Thank you so much, Dr. Mikhael, for taking the time to come here on a busy Wednesday afternoon to teach us about myeloma research.
Well, thank you, my friend. It's always good to see you. And even in a virtual capacity, I get excited when I'm visiting Canada. As I'm sure many of you know, that is my homeland. That's where I was born and trained and worked for many years before I made the trek south. So thank you so much, Gabriel, for inviting me to do this. And thank you so much for Myeloma Canada and all that you do for patients. What I thought we would spend our time doing here in the next 40 minutes or so, and then give you an opportunity to ask questions, as was already noted, is to really think about where are we right now in the most recent research in myeloma. I could bore you for hours and hours about so many things. I've tried to narrow the focus a little bit into sort of 5 key areas where we saw a lot of updates recently, mostly at ASH, or the American Society of Hematology meeting, which we hold every December. And out of that meeting comes really a tremendous amount of work and research as we go forward. So I think I just need to be given control. Oh, there we go. So what are these 5 arenas that I want to briefly talk about? I want to talk about these screening trials. I mean, the word screen is not something we've historically ever used, frankly, in multiple myeloma. It's not something that we've been discussing for almost any period of time, because it's just not been something we've been thinking about. But now there are several studies being pursued that are helping us understand this space. Then I want to spend a little bit of time talking about frontline therapy. There's really so much has changed, and trust me, I'm very aware of what is and what isn't, unfortunately, available in Canada. So I'm not going to be able to immediately apply this to the Canadian system, but as much to give you a sense of what's happening on the research side. And most of these things haven't even fully infiltrated the US either. We know that often, sadly, there's a bit of a time lag there. But nonetheless, and not to show you what you don't have, but to show you what is really been promising in the world of research. We'll have a short little third comment about early relapse. There's just a couple of small things that are starting to influence this space. And then probably the area where there was the greatest attention at ASH this year, and really in myeloma research in general, are these emerging or newer treatments. I'll try to make sense of some of them without boring you with all of the data, to just give you a flavor of what's to come. And then, as some of you know, I'm particularly dedicated to the issue of health disparities. This is something that is frankly a problem worldwide, but is a particular challenge in multiple myeloma, as I'll share with you, in particular within the African American, even African Canadian community, but also in many other communities as well. And so we'll talk a little bit about the research that's going on there, and I'll put a quick commercial in for some of the work that I do in this field. So when it comes to the screening studies, there were two large influential studies that I want to make brief mention of. The one is called iStop and one is called PROMISE. And so the background here, as I've already intimated, is that we really haven't thought much about screening in myeloma, but screening is important in cancer. We know this has changed the way we diagnose breast cancer, to a certain degree prostate cancer, and even in some capacity skin cancer and others, where we have these larger screening programs. But we've not really done that in myeloma. But we know that there are particular groups that are higher risk, particularly African Americans I've mentioned, but also as we get older, we have a greater risk, and there are other things that we're going to see and explore here a little bit. And it's hard not to think about a screening study in myeloma and not talk about the iStop study, or Iceland Screens, Treats, or Prevents Multiple Myeloma. That's what the acronym iStop stands for. And this has been many years in progress. I remember many years ago being involved with Sigurdur, the first author here, and we were at a meeting actually in Edinburgh, Scotland, and kind of on the back of a napkin, we mapped out the concept of this massive screening study, where the intent was to screen every adult, frankly, in the whole of Iceland. And you're going to see the numbers here are just simply staggering. And so the idea was, in all those that would participate, that we would do those natural screening tests that we would do, and determine how many of them have MGUS. You may be familiar, of course, with MGUS is the pre-myeloma condition, where people have that abnormal protein in their blood, but they're not actually sick with myeloma yet and may never become myeloma. And then they were randomized within, once diagnosed with MGUS, to really not have to follow them up, to follow them up the way we normally would, or to follow them up very intensely. So part of the concept here is there going to be a benefit of intensely following people going forward? And so the multiple aims, I'm not going to bore you with every single one of them, was what can we do if we start on a large scale screening program for MGUS? Now, there's lots of reasons why we would choose Iceland. Geographically, it's more isolated. Genetically speaking, more people there have had their what we call genome sequence, where we've mapped out the whole of their genes than in any other country. But understand what is the right workup, what is the right follow-up. Can we make a connection? Is there some strong genetic link in myeloma? Are there certain what we would call germline markers? Are there certain things in people's inherent genes that put them at risk? And maybe we could ultimately alter those and never develop myeloma. That's the ultimate, of course, in prevention. But understand also what screening does on quality of life, biobanking, and then determining if we should treat people earlier. That's going to be a later part of the study that I'm not going to talk about today. And so in this period of time from November 2016 to October 2018, nearly 81,000 patients agreed to participate. I mean, one of the largest screening studies in history, largest by far in myeloma, of course. And we've already collected over 75,000 samples with this. And so that's already landed nearly 4,000 patients with MGUS. I mean, that's a lot of people with MGUS. We excluded those who had known MGUS, about a few hundred of them, and then also discovered, unfortunately, that there are people that had true active myeloma just in the screening process. And so I mentioned there was the randomization between the three arms. I'm not going to focus as much on that. But apart from saying that, when we are more intense in our follow-up, we pick up myeloma more quickly. Obviously, the old adage, if you don't take a temperature, the patient doesn't have a fever. If we look for something more carefully, you can see the number of patients. So they concluded that after screening this over 75,000 people, that when we more intensively follow people, no surprise, we find more cancer, whether it's active myeloma or smoldering multiple myeloma, and that we find that we can have a better approach to early detection. Now, all this being said, we're not by any means suggesting that we're ready to screen. It's just setting the framework to understand the screening process a little bit better. So my commentary on this, I mean, it's just unbelievable to think we have that many people that have been screened. We're going to be learning from this study over the next decade or more, where we're going to answer questions like, really, how common is MGUS and smoldering myeloma and active myeloma? What does MGUS mean if someone never develops myeloma? So we can follow all of these MGUS patients now. They have a unified healthcare system there. And we're starting to discover, oh, wait a minute, here's an opportunity where we can learn, maybe it's associated with other diseases, even if they never develop myeloma. And can we discover, as I mentioned, the genetic basis of the disease? And ultimately, should we screen everybody? Should we just choose certain populations? Is it, you know, when we screen for colon cancer now, we don't just say everybody. We have an age, family history influences that, race may influence that. So those are the kinds of things that we may be thinking about in myeloma. To further understand this, the PROMISE study that I had a privilege of being a part of went a step further in one way, but obviously not as dramatic in screening the whole of a country, but wanted to screen patients at higher risk. For those who are over the age of 40 who are either Black or had a family history of a hematological malignancy. And I won't go into as much detail with this study, as apart from saying, if we think that roughly 5% of the country has MGUS, at least people over the age of 40, in this group of patients, the risk was much higher, 13 to 17%. So double to triple what we would expect, and particularly those patients over the age of 50. And when we use more sensitive, no surprise, techniques like something called what's MS here, or mass spectrometry, we can detect these MGUSs even earlier. So, you know, putting this all together from the screening standpoint, it's too early to say that we're doing anything differently in myeloma than we were 6 months ago with this information. But we've definitely shed a light in trying to understand this condition better. And as we always say in medicine, you know, you can't fix something, you can't treat something until you understand it. And so we're trying to understand it better. So lots more to come in the years. I'm going to predict that for the next decade, we're going to be learning from these kinds of studies. So what about frontline therapy, where there are 3 studies that I want to update you on, 3 great research studies, something called the Griffin study, something called the Master study, and something called the GMMGHD7 study. I don't come up with these names. As we think about the background here, what we're starting to do is using more drugs up front. And I know in some ways patients are excited to see more drugs because it may mean that they're going to work better. But another way, when we add more drugs, we have more risk of side effects, or toxicity as we call it. And so that's going to be a challenge. And so are we ready to go from what we've typically used as 3 drug combinations, things like VRD, Velcade, Revlimid, dexamethasone, or CyBorD, cyclophosphamide, bortezomib, dexamethasone? Are we now going to 4 drugs where we're adding daratumumab or one of these other drugs like isatuximab to a 3-drug combination to make it 4? Here in the US, we already have a 4-drug combination for people that are going to transplant, something called DVTD, so daratumumab, Velcade, thalidomide index, but we really don't use a lot of thalidomide. And so we rather replace the thalidomide with lenalidomide or Revlimid, and you'll see some of the work being done on that. And then if we do use these 4 drugs, how long do we have to give them? As I'm going to share with you in a moment, one of my greatest objectives as a myeloma doctor and as someone inherently involved in the myeloma community is to learn stopping rules so that we don't always have to treat people indefinitely. I love to give people nothing. It's my favorite drug, nada, as it were. Or rien en français, for those who are French speaking here in Canada, that it's patients love when they're on nothing. And even though it seems that we just keep adding more and more drugs, the hope is that we can reach a point where we give them nothing. So the Griffin study, and there was a lot of words on this page, was it's a little bit easier in the next slide, where we gave the standard RVD, or Revlimid, Velcade, dexamethasone, in these orange boxes, and compared that to what happens if we add daratumumab to that, or Darzalex is the trade name there. That's the drug that hooks onto something on the outside of the myeloma cell called CD38 and triggers the immune system to destroy it. So you have 4 drugs in purple and 3 drugs in orange. and they were given cycles before transplant, then given a transplant, given a few more cycles, and then continued on in maintenance therapy. Often we use Revlimid maintenance. I know not in every context in Canada is this available, but typically we give Revlimid maintenance. But here in the forearm side, or patients were getting daratumumab, they got 2-drug maintenance, daratumumab and Revlimid for 2 years, and then just Revlimid alone. And I know these numbers may be difficult to capture, but what's in the darkest color, be it purple or orange, is the depth of response after each of those segments. So after the first few cycles, after transplant, after more cycles, and after 1 and 2 years of maintenance therapy. And even without looking at the numbers, you see those bars getting darker, which means more and more people were getting responses after each of those treatments. But you see that there's more purple here than there is orange, meaning when we give the 4 drugs, we get a deeper response. They were comparing, if you look at the very last line of each category, a complete remission, where we can't really detect the disease anymore, we saw was 82% in the DVRD arm and 61% in the RVD arm. So 61% is pretty good to get that many people without detectable disease, but we upgrade that by about 20% having given that daratumumab. So that's really quite an impressive result. It's too early for this to be what we call statistically significant. And remember, in this kind of curve, you want to be flat as possible, because every time that curve drops, it means someone relapsed. That the 4-drug combination does look better than the 3-drug combination. It's not separated enough to really say it's what we call statistically significant, but amazing. At 3 years, 88.9% of people on the DVRD arm still haven't relapsed, whereas 81% in the RVD arm have. And so I think we are seeing that this isn't just getting, I always talk to every patient of mine, the 2 Ds of response, depth and duration. And here we're definitely seeing that there is both depth and duration to this kind of response. Well, that was one study. Remember I said there were 3. Study number 2 is what's called the master study. And the reason why I include this, even though it's smaller and it's not going to immediately change things, I love the design of this study. I remember sitting in Luciano Costa's office many years ago, pre-COVID, discussing how we could design this. And I know there's a lot of letters here and numbers and so on, but let me simplify it. We're also now giving 4 drugs. Instead of daratumumab VRD, we're giving daratumumab KRD. So we're replacing Velcade with Kyprolis or carfilzomib. And what's different here is, instead of just keeping to give the drugs forever, we give the drugs for a period of time, and we're always checking to see if there's any measurable disease left through what we call MRD testing, or minimal residual disease testing. And if someone gets into MRD negativity, where we can't even detect it, then they can come off treatment. And testing this hypothesis, do we have to keep, treating patients over and over again, even if they reach that MRD negativity? And basically what we showed was, in most patients, this was actually a reasonable strategy. If people had 0 or 1 of these, what we call high-risk cytogenetic abnormalities, those lines were pretty flat. Those patients stayed in remission for long periods of time. The first graph here is about time to relapse. The second one is overall survival. However, in those patients that have what we sometimes call in myeloma ultra high-risk disease, we know that myeloma has a huge spectrum. There are people that have very little that actually can do very well with myeloma, and unfortunately some patients that have very aggressive myeloma, that no matter what we do, sadly their survival is shortened. The overall survival of myeloma right now is probably a decade, to be blunt, but in the high-risk population it's still probably under 3 years. And so what the study was showing is that that those patients that have that highest risk disease, it's probably not a good thing to stop their treatment, because if we take our foot off the gas, as it were, then the disease starts to grow back. And so this was a very, I think, influential trial in the way we think about the disease. And then lastly, just from completeness sake, similar to the first study we showed, but now in a big, what we call phase 3 study, which was really comparing the standard of care VRD to now adding another drug to it. Instead of daratumumab, this was a drug called iStopMM that I've had the privilege over the years to help develop. It's a drug quite similar to daratumumab, but has unique features to it. And so again, here with the iStopMM plus RVD versus RVD, they only reported the early part of the study, because the study was started a bit later. where they gave about 18 weeks of 4 drugs versus 3 drugs. These patients haven't even had a transplant yet. And it was interesting, instead of just looking at response rates, they wanted to look at MRD negativity, meaning how deep a response did we get? And sure enough, half of those patients in just 18 weeks got into MRD negativity with 4 drugs versus about 35% or a little over a third in those who had the 3 drugs. Again, giving credence to this notion that more may be better in myeloma. I mean, we don't know how much more. Are we ever going to go to 5? Who knows? But definitely an improvement, and that was really exciting. So if you've been napping for the last 5 minutes, let me bring you up to speed on what I've said about frontline therapy. Adding a CD38 antibody, whether it's daratumumab or isatuximab, is feasible. We can do it, whether it's giving it to VRD, Velcade Revdex, or carfilzomib or Kyprolis Revdex, KRD. We know that we can do that without a lot more so-called toxicity. Look, there's always every drug comes with a risk, but thankfully those risks are not too dramatic. We know that when we do that, we improve the depth of response, including MRD negativity, and it looks like we're also affecting the duration of that response, the progression-free survival, or the time in which someone remains in remission. This may be helpful in overcoming some of those high-risk features. And it reminds us, like I said before, we need to build a strategy to stop treatment. I really think this is important. I don't want to tell every patient you're going to take it and you're going to like it. That's not what we want to do in myeloma. We want to find a way to stop people's treatment. That being said, there is that subsegment, maybe only 10-ish% of patients, but not an insignificant number, who have this very high-risk myeloma where we need a new strategy because the drugs we're using and the approach we're taking is not enough for these patients. Now, if we turn our attention for a minute to relapse, I put this table up because it's impossible to read. I don't do this because it's a busy slide, as some people say. I always say busy slides are lazy slides. I did this purposely to be overwhelming, to say that we have so many choices in relapse myeloma. We could spend hours talking about it. And even though many of these choices aren't immediately available in Canada, we're working towards that. And I hope you know many of us work very hard to try and make sure that happens. But the choices are really growing, and this is good, right? I've joked sometimes that this is like you go to one of your restaurants where they have one of those huge menus, like here not too far from me, and my kids sometimes like me to take them to the Cheesecake Factory, and I always say the Cheesecake Factory menu needs its own table of contents. It's ridiculous how thick it is, and that's kind of what's happening in myeloma. We're getting more and more choices, which is good. More choices on the menu means you can match the choice to the patient more effectively. And so when we approached relapse myeloma, it's not just this is what we always do first, this is what we do second, we do third. We put people into categories. So I'm going to divide these next 2 sections. So we've talked about screening studies, we've talked about frontline therapy, we're going to talk about relapse now, early relapse and late relapse, and then we'll talk about health disparities to close off the talk. But as we talk about relapse, we think of kind of early and later relapse. So early relapse is maybe the first 2 or 3 lines of therapy, which I'll show you has a real impact on what we do. And then we'll spend a lot of time talking about so-called triple class refractory myeloma, which means when people have been treated with the 3 major classes of drugs. And as we treat, a few important principles remain. The depth of response really does matter into how we care for patients. I think we're going to be using a lot more guidance from MRD testing in the future. There's a big difference between high risk and standard risk, as I've already shared with you, and we may need to be more aggressive in high risk. We always have to balance efficacy and toxicity. Going back to what I said before, it's one thing to say, look, we got to get through this treatment. It's only a couple of months. I start telling people, you got to be on maintenance therapy for 5 years. That's a big problem if it's affecting their quality of life. And remember, you as a patient, no matter what scales we have, your definition of quality of life is the most important definition of quality of life. And then when possible, we want to so-called overcome drug resistance. And this is why often we use multiple mechanisms of action or several drugs at the same time, or when the disease grows on those drugs, we make sure we change tact and use a different kind of drug. Because this disease, and this picture is just meant to show you that with time, the disease becomes more aggressive. It gets harder to pull back down again. It stays in remission for a shorter period of time. Or another way to look at the same concept is, unfortunately, with every line of therapy, there are fewer patients available eligible for treatment because some of them have died. Some of them don't want any more treatment. Some of them, their disease is not able to be treated anymore. And so it's incumbent on us to do the best we can in those early lines of therapy to give patients a long-term benefit. And so lots of guidelines exist. We published a paper recently as the International Myeloma Working Group, or the IMWG, led by Philippe Moreau from France, who divided up relapse into two categories: are people not refractory or refractory to myeloma, to lenalidomide, based on the fact that many patients get lenalidomide as maintenance therapy. And I'm not going to go through all these, but to show you that we have options. Sometimes we have preferred options or less preferred options. Also depends on what's available in the country that people are being treated, but at least we have choice now. And in the research update theme of the day, we've had a few updates, nothing major, I would suspect. I'll give you just a moment on what's called the Apollo study. And then we are using drugs that we've typically saved for much later, things like selinexor and belantamab, which I know are not as easily accessible yet in Canada, but we're working towards that for both of these drugs, actually. And I've been a little bit of a part of that we can now bring them a little bit earlier in the disease course. So the Apollo study down here in the bottom left-hand corner is a study where we give daratumumab with pomalidomide and dexamethasone. And we give the daratumumab actually subcutaneously in the skin to save people the long infusions that daratumumab has. And it's just to remind us that we have all these different studies. I know this looks like an alphabet soup here, but it's using the three key drugs here of the proteasome, three classes of drugs: the proteasome inhibitors, whether it's Velcade, or in this case focusing on carfilzomib, because most people get Velcade in their front line. So at relapse, we want to give them a different drug. So we're giving them carfilzomib with a K. And we're pairing that up either with daratumumab or isatuximab, so Candor versus Ikema, or instead of giving K, we give P, or Pomalyst, or pomalidomide, where we're also pairing that up either with daratumumab or isatuximab. So now we have 4 big phase 3 clinical trials where we keep getting these updates. I've had the privilege of being involved with many of them, where we're starting to see that sure enough, 3 works better than 2. And when possible, and I know in Canada it can be tricky, and in some contexts you're only allowed to ever get 1 triplet, and especially in Ontario, I know some of these challenges, but we are trying to push the envelope here and demonstrate that when patients get 3 drugs, it's better than 2 drugs. Now, as we look to the future, we're going to be using even newer drugs. And so I created this schema, and I'm updating it soon in the next edition of Myeloma Today. So hopefully you're reading your Myeloma Today that comes from the International Myeloma Foundation, along with the great updates that come out of Myeloma Canada, where the drugs I talked about before, like isatuximab and daratumumab, are like that drug on the far left, where it's what we call monoclonal antibody, or a drug that hooks onto that CD38 and can start to kill the cell that way, but also kind of makes a phone call to the immune system to come and destroy it. We also have a different target, something called SLAM-F7, and we use a drug called elotuzumab. But then we have 2 new mechanisms here. One mechanism is in the middle there, where there's a drug that's got a little blue tag to it called a toxin. So what happens is this drug, kind of like daratumumab or isatuximab, it hooks onto something on the outside of the cell. In this case, it happens to be something called BCMA, or B-cell maturation antigen. Instead of making a phone call to bring the immune system to kill it, it does that also. In addition, it's got a backpack, if you will, that has a toxin in it, or something that can be damaging to the cell, and it drops it into the cell. So it's kind of a intelligent way of damaging the cell, very targeted though, because that toxin's only going to get dropped in if that cell has BCMA in its surface. So it can hit the myeloma cells and not the other cells. And then in a couple of minutes, I'm going to talk to you about this other drug that I've sort of tried to envision on the side here, which are basically 2 antibodies merged together, what we sometimes call bispecific drugs, where these drugs do 2 things. They hook onto the myeloma cell, like the BCMA here, although as I'll show you, there are different targets, and also hooks onto a local T cell and engages that T cell. So T cells are part of the immune cells, the soldier cells in our body, and these cells now can be engaged to help destroy the tumor. I mean, this is really quite amazing when you think about what's happening. The other even more extreme version is something called CAR T cell therapy, which we now have approved here in the US, which is a lot more complicated, but we try to simplify it in an image like this, where what we do is those T cells that I just showed you in a moment, we actually take them out of a patient. And in the lab, we do two things. We engineer the cells to really recognize the myeloma, specifically in this case, the BCMA target that's on the myeloma. But secondly, we can also multiply them. I mean, I collect hundreds of T cells from patients. I'm going to give them millions back. And then I give them back to the patient. So it's more involved. It requires collecting the T cells. For those of you who've been through stem cell collection, it's pretty similar, where we have to hook you up to that machine, pick off the T cells, give you your own blood back, do this whole manufacturing, and about 4 weeks later, we give you those T cells back. And so as we look to the now guidelines for people very heavily pretreated, we don't have as many options, but these options are all in the sphere of what I shared with you just a minute ago. And so when we look at the recent research updates, it's really amazing what's happening in CAR T cell therapy. And I'm going to share with you just a little bit from what's called the CARTITUDE-1 trial, which is a study that actually since ASH, just last month here in the US, we had approval for this new CAR T cell therapy called cilta-cel, or Carvykti is the trade name. And then there are just, actually I really should say 10 of these bispecific drugs that have this two-arm nature, one arm that hooks onto the tumor, one arm that hooks onto a local T cell. And we saw, as I say, at least 10 of them, several targeting BCMA. But now we have even 2 new targets, something called GPRC5D. I know it sounds like a Canadian postal code or a license plate. Another one called FCRH5. But this is important. This is great because we want to find new ways to attack the myeloma, because we know sometimes we use one target, after a while the disease gets smart and it won't let you attack it that way anymore. So we kind of go a different way, because sometimes I say it's like you go in through the front door, eventually the enemy figures out, locks the front door, so we got to get through the side door or the window or the back door. And so we're always trying to discover new ways to attack multiple myeloma, and these drugs are different. Whereas that CAR T cell therapy, I give that big whopping dose of CAR Ts back to the patient once. Now, in one way, that's very attractive. It's the one and done approach, where the patients get treated. I mean, I had a patient recently come to me and say, "Hey, doc, look, I love you, but I'm glad I'm not seeing you that much." He had a CAR T cell on a clinical trial, and he's been in remission for years now, which is wonderful. And he says that the best I felt, doc, I don't have any chemo brain. But it's challenging. We have to go through that whole process I described. These bispecifics tend to be given more on an ongoing basis. So to tell you about, probably if I really only were allowed to show you one study from ASH, it would be this one, the CARTITUDE study that tried this new CAR T cell therapy that since this presentation it got approved, the cilta-cel drug. And I won't bore you with all the details, but again, people have this what we call apheresis, or where we collect their T cells. We give them a little bit of chemo before we give them those T cells that we've engineered back. And this is the slide. If I could only show you one slide, it would be this slide. 98% response, 95 out of 97 patients. I mean, if I can use the word, in myeloma, this is redonkulous. Like, when you think of how heavily pretreated these patients are, the best of the best we had before this, maybe 25 to 30% response rate, and maybe lasting for 3 to 4 months. Now we have a 97.9% response rate. 95% of them have what we call a VGPR, very good partial remission, which is defined by a 90% reduction of their tumor. And what's maybe even more exciting was how long it lasted. That on average, people stayed in remission for over 2 years. You gotta understand, these are patients who, prior to this, we would have expected them to live maybe 6 to 8 months. The overall survival, 3/4 of patients are still alive at 2 years. So even as geeky hematologists, this was like jaw-dropping to us, right? Like, this was really quite an impressive change. And then just to let you know, there was another study called the CARTITUDE-2 study, where instead of using this at the very end after people had relapsed on everything, we've actually started to study it now earlier on, in that early relapse phase I described earlier, 1 to 3 prior lines. I won't give you all the data from it, but bottom line is we're seeing similarly a remarkable response rate in patients as we treat them with this drug. And then lastly are the bispecifics. I mean, of course, there are other things that I could talk about, and I've already sort of covered a little bit of this, but there are so many of them, as I've already indicated. The challenge that we see with CAR T-cell therapy is people develop this kind of new side effect to us, something called CRS, or cytokine release syndrome. It has to do with the fact that when we give these T cells back, the immune system kind of gets triggered. We're breaking up bad cells right away, and the body has a reaction to it. And some people actually get really quite sick with it. And so we have to, right now at least, do this all as an inpatient. We see the same thing with bispecifics, but in a much lesser capacity. So fewer total patients, but also fewer total cases of CRS, but also milder, meaning we don't see the higher grade CRS that really require people to go to the ICU, the intensive care unit, or things like that. And so it becomes a very attractive feature. Again, I know there's too much information on the slide, but I just want to give you a flavor. I mean, here are the kind of the leading 6 right now of the bispecifics we have, and just to see that we have this many. Most of them are now on BCMA, as I mentioned, but we have these new targets. Some of them are given subcutaneously, some are IV, some are given every week, some are given up to down to even just once a month. They all have some risk of CRS, and they all have some risk of what we call neurological toxicities, but thankfully less than what we see with CAR T-cell therapy. If we try to get just a general ballpark, the response rates in these drugs are at least double what we've historically had with other drugs. So if the historical 25 to 30% existed, now we're seeing more like 60, 70% with bispecifics, and of course, as I showed, over 90% now with CAR Ts. And so the leading bispecific is a drug called teclistamab. And you can see how it's pictured here as this sort of 2-armed drug, blue and green, that wedges itself between the myeloma cell and the T cell and engages them together so that the T cell can help destroy. And as I showed you, I mean, response rates are impressive, 62%. Again, literally double what we have seen with just about every other drug in this kind of context. Now, they do come at some risk. There's lots of detail here. I bring it down to really 2 things. There's some of this, as I mentioned, cytokine release syndrome, or CRS. Thankfully, almost all what we call grade 1 or 2, and that is important because the difference between grade 2 and grade 3 CRS is a big difference. Grade 3 CRS is much more worrisome, where people really have to be in an ICU setting. We can handle most of grade 1 and grade 2 pretty conservatively. The other thing is it does definitely put people at risk of infections. And so we're still trying to sort out the best way to prevent and treat those infections, but it's something we have to keep an eye on as we go forward. But thankfully for the cytokine release syndrome, although the majority of people on teclistamab got cytokine release syndrome, as you can see, 50% were grade 1, 20% or so were grade 2, and just a tiny fraction, this one patient actually had the grade 3. So it's usually quite manageable. So what do I say about late relapse? I mean, this is unprecedented response rates with CAR T. I can't emphasize this enough. We're going to have even more options. We're talking about whole new ways of giving CAR T cell therapy. These bispecifics, amazing, multiple targets, and different ways of giving it. I haven't even had time to tell you about other new drugs. We have 2 other new drugs that are being developed in relapsed myeloma, something called iberdomide and something called modakafusp, which I think both are showing some promise. And who knows, we may be able to do so-called allo-CAR. So instead of having to collect someone's T cells, we could just manufacture T cells kind of off the shelf and give it to a patient. And then even in the bispecifics, we've talked about T cell engagers, but now we're looking at this thing called NK, or natural killer cell engagers. I'm doing a clinical trial, for example, right now in that field. And the attractive feature there is not only natural killers, I mean, they sound pretty scary, right? They're good at killing tumors, but they also invoke much less CRS, or cytokine release syndrome. And so that may be easier to tolerate. Well, before I close, let me remind ourselves of another major and critical area of research. I have the privilege of leading the IMF's effort in diversity, and in particular, what we call the Empower program that I'll share a slide with you at the end on. You know, myself, born and raised in Canada, but of African descent, this is a really near and dear topic to me. And I always start by reminding people of the basic facts. I'm not going to go through this in a lot of detail for time's sake, but if we look here in the US in particular, and we're seeing the same trends in Canada and many other Western countries, that there's a longer time between someone's initiation of symptoms and diagnosis in this population. I mean, we know in all myeloma patients often, I mean, there's a recent interesting British study showed that most myeloma patients are seen 3 times by their primary care doctor with signs and symptoms consistent with myeloma before the diagnosis is made. So there's a delay in everybody, it seems, but that delay is even more so within the African American community. African Americans are younger, they have twice the likelihood of developing myeloma, and they're definitely less likely to receive what I call the big 3 T's: triplets, transplants, and trials. And by the way, now we can add a 4th T to that, frankly, CAR T-cell therapy. We're seeing early on that less Black patients here in the US are getting CAR T-cell therapy. There's some biological differences, and maybe the most worrisome feature is that survival, it's not just the disease is more common. The average survival in the Black patient is half of that of what we see in white patients. That's just not acceptable to anybody. On the other hand, the shining light that we see, the opportunity we see here is in certain contexts when access to therapy has been the same, we know that Black patients can do as well, if not better. So it's not acceptable to say, well, you know, Black patients, maybe they have more aggressive disease and therefore don't do as well. No, if anything, they have less aggressive disease and they have the opportunity to fare better. And so at ASH this past year, there were over 20 abstracts specifically dedicated to this topic. Most of them, as I like to say, focused on the diagnosing the problem instead of fixing the problem. But that's okay. You know, in doctor mode, I got to diagnose before I treat. So we need to understand the problem, whether it's systemic racism, access to therapies, trust in the system. I mean, there's a whole series of factors that we can evaluate, socioeconomic status. But the themes were that sadly we see inferior outcomes. There's still a delay and inequity, even in the diagnosis. African Americans are less likely to get a bone marrow test done in a timely manner to be able to confirm the diagnosis, which we need for myeloma. I mentioned the disparity to the 3 T's: triplets or 3 drug combinations, transplants, stem cell transplants, and trials or clinical trials. And now we can add a 4th T: CAR T-cell therapy is less accessible to them. We saw a lot of discussion, even in the live meeting at ASH when we were in Atlanta, about the lack of representation of African Americans in what we call pivotal clinical trials, those trials that actually lead to drug approvals. And I've already mentioned the socioeconomic status correlation. So the IMF has developed, and I'm going to come to an end here, so I'm not too long a commercial, but we've developed something called the Empower Initiative, which is part of the African American Initiative, which is to improve outcomes in African American patients. And we do this in multiple ways, but bottom line, we engage the community to raise awareness around myeloma. We engage both the medical and non-medical community to do this, but we're also focusing in the primary care world, primary care physicians and nurse practitioners and others, to help them in the early and accurate diagnosis of myeloma, while also supporting the hematology oncology community so that we can find better ways to access. And here in the US, in particular with a lot of the insurance challenges, this is a real big issue. We started as a pilot in Charlotte, North Carolina, but now we've moved to multiple other cities. Obviously, a lot of this has to be done on virtually, as it's been difficult, but we launched our Empower Charlotte website. We've had over 200,000 hits on it, where people can learn about the disease. Could I have myeloma? Do someone I know could have myeloma? When should I get tested? How should I get tested? If I do have myeloma, how do I get support? How do I get access to resources, to financial resources and others? So we've really tried to create a very engaging website. We've interviewed some famous people. If you're a hip hop fan, you may know who Dougie Fresh is. And I did an interview with Dougie Fresh to raise awareness around this. We've created a Myeloma Made Simple video. I've done a whole series of videos and talks so that we can raise awareness around this concern. And we've also done targeted educational projects specifically to primary care physicians so that they so-called don't miss myeloma. You know, what are the signs and symptoms of myeloma so that they can make the diagnosis more accurately. Myeloma's changed so much in the last few years. When I first studied myeloma at Princess Margaret Hospital to over 20 years ago now, it's amazing how much has changed since then. We've developed all these new drugs. Another way of looking at it on this next slide is you see all of these new drugs in black we've had for a long time, red more recently, and then green even more recently, and purple what's coming and what is now established. It's amazing how myeloma has changed, and we want to work towards a cure and help those patients who are fighting this disease all across the world, really in a unified effort. It's such a privilege to be a part of the IMF and the international effort to try and overcome this illness. So I'm going to stop there and turn it back to our gracious host. And we have 15 minutes, as I promised, mon ami. We have time for some questions. I'm happy to receive any questions you have. And I hope this has been helpful to you as we think about this disease together and try and conquer myeloma together. Thank you.
Thanks, Dr. Mikhael, for all that information. And I always love the way you present and how you simplify everything. I think it was just great, and I'm getting lots of comments that echo that. So let's start from the beginning. So please do send in your questions. I do see a few here, but before we get to those, I'll just ask a few of my own that I've thought about while the next ones come in. So at the beginning, we talked about screening. We talked about iStop and PROMISE studies, and how in the iStop, the prevalence of MGUS was seen to be about 4.9% of the population. Now, you did mention that PROMISE used a more sensitive approach, such as mass spectrometry. So would it be safe to say that the true prevalence of MGUS is probably higher than 4.9? Yeah.
Yes, it's a great question. In fact, we're starting to learn, because we use mass spec in Iceland as well. We're starting to learn that it probably is higher than we initially think. As we the data comes in, we'll know more. It's interesting, not just MGUS, we're seeing about 0.5% of all people in Iceland have smoldering myeloma, which is remarkable. So it's not just MGUS, it's all of that pre-myeloma, pre-active myeloma condition. And yes, I think we suspect, obviously it depends on who you're studying, right? If you're studying, obviously there was an age cutoff in both of the studies, but the other thing we need to understand and reveal better is, what really constitutes MGUS, right? Historically, we measured MGUS by the old school testing of what's called the serum protein electrophoresis and light chain measurements. Now that we're using more sensitive techniques, which I think is good because it does pick it up earlier with mass spec, we have to be careful we don't overdo it and maybe pick up tiny little bits of protein that may actually never be important. So we're going to have to follow patients for a long time to understand. But there hasn't been as big a discrepancy between what mass spec found and our more conventional tests to really make us feel that we're over or under calling it. But you're right. My gut is that 5% number we throw out for people over the age of 40 may be a little bit undershooting it. It may be more than that.
Cool, thank you. Next, we talked about immunotherapy. So different types of new drugs that are being researched right now. And I'm just wondering if you could explain to us a little bit the difference between something like immunotherapy and something like a conventional therapy, like let's say a lenalidomide, for example. My understanding is that the difference between both of these things is that immunotherapy kind of, like you say, it does a telephone call to your immune system. Now, I was under the impression that the other drugs also did some of that. So can you maybe just clarify?
Yeah, it's such a great question. No surprise coming from you, my friend. I mean, I know, and this is a lot to do with terminology. So the phrase immunotherapy is kind of a hot topic right now, right? That's the word that people want to hear and use. And so everyone wants to say, no matter what drug they're being used, that it's immunotherapy. And part of it I get. I mean, there's no perfect definition of immunotherapy. The intention of the word immunotherapy is to say we're engaging someone's own immune system in the destruction of the tumor, as opposed to, old school chemotherapy, like the bald and barf kind of chemotherapy, like we give high-dose melphalan or cyclophosphamide, which is really kind of externally coming in and blasting someone's body, not so much using the internal resources of that patient. The benefit of immunotherapy, or the concept, of course, is that it's someone's own immune system, so they're not going to, if you will, reject it. It's going to be more precise in its measure, in its damage, that it's not going to, damage the whole of the body like we would with that sort of external force. But that also, it has the opportunity to have a much more sophisticated and targeted approach. Now, you're right. I could argue that drugs like bortezomib and lenalidomide or Velcade and Revlimid really have a component of immunotherapy, because there is some signaling pathways and so on. They're not so much the older school chemo. I kind of think of it in almost three buckets now. There's really the older school, very traditional chemotherapy. There is the more biologic therapy, as I sometimes say, for drugs like Revlimid and bortezomib and even selinexor and some of these newer ones. And then there's the really more true immunotherapy, the monoclonal antibodies, CAR T-cell therapy, bispecifics, where there's much more engagement. Now, major caveat here, myeloma is a cancer of the immune system, right? I say this to patients all the time, so we have to be careful. Like when a patient comes to me and say, "Oh, doc, you know, I saw this commercial, I read this thing in my health store that I can take this to boost my immune system. Isn't this going to be the right thing to do?" Well, it may be, but you don't want to boost the wrong part of your immune system, right?
Yeah.
So I think we just have to be careful. I mean, I learned about the immune system from a brilliant hematologist, Lothar Hupsch, at the Ottawa General Hospital, L'Hôpital Général, as we used to call it, and in Ottawa. And I remember him explaining to me, he's like, you know, don't forget how complicated this is, right? And he showed me 6 different patients on the floor and showed me how differently their immune systems were reacting. And that's when I realized my world got a whole lot more complicated, right? And so I think we just have to be careful about and be respectful, frankly, at the complexity of the immune system. But, you know, we do try and put it into buckets. You know, we have, you know, what's called a humoral immunity, or through antibodies. There's so-called cellular immunity, like what the T cells do. And we're trying to leverage every one of those bits of the immune system as we treat patients. I hope that answers your question, my friend.
Absolutely. Thank you. So we do. I guess I'll move on to I do have more questions, but in the interest of time, I'll move on to the questions that the audience is asking. So we're going to go with CAR T cell therapy. So let's move on to CAR T. I was going to go there anyways. Now, I mean, I guess I don't know if we should ask this quite. Well. So who qualifies for treatment when it comes to CAR T cell treatment? So I guess, you know, can older adults receive this treatment? Like we know that for transplant, there's a cutoff. Is that the case for CAR T cell treatment?
Yeah, that's a fantastic question. And I'm sorry, in one way, I didn't get time to cover during the talk, because, you know, there's so much we could say about CAR T. I kind of wanted to just give the sort of the high level research update. But sort of 2 questions in one here. The first part is, who is eligible for CAR T? So, you know, typically the way drug development works in cancer, and in particular myeloma, is you kind of have to prove yourself in the most resistant, heavily pretreated setting, typically by yourself, and then eventually it can be treated or used earlier in disease course. Like daratumumab did this. It proved itself as a single agent in people who basically had no other option, and then we started moving it back, and now we use it even in frontline therapy. So CAR T right now, the approval for both CAR T regimens are almost identical. People must have had 4 prior lines of therapy, not just 4 different drugs or therapies, lines of therapy. And for example, induction therapy with transplant and maintenance, that's all 1 line. And then the disease relapses, they get treated with something else. The disease relapse, they get treated with something else. That has to happen 4 times before they get CAR T, and they have to have been treated with drugs from each of those 3 major classes that we talked about before. Now, interestingly, a little bit like stem cell transplant, obviously we have to set some parameters, because CAR T can be difficult. It requires that apheresis. It requires 5 days before we give the cells back, we start people on some chemo, not super high dose chemo, but high dose chemotherapy enough that it can limit who can get it. The simple way of describing it is that it is restrictive compared to things like, let's say, bispecifics, but it's not as restrictive as transplant, because we don't think it's quite as intense as transplant. So meaning, just because someone was not eligible for a transplant, and I know in some provinces in Canada, there is even a frank age cutoff, although we've pushed, you know, I led the ASCO and Cancer Care Ontario guidelines for myeloma, and we were very emphatic to say, don't be ageist. You know, there's not something that magically happens on your 65th or 70th birthday that all of a sudden makes you ineligible. I understand that sometimes age is a contributing factor, but we're developing better what we call frailty scores and fitness scores to better understand someone. The way I tend to think about it is, generally speaking, anyone under 65 is mostly going to be eligible for transplant. Over 75, not likely. 65 to 75, we really got to look carefully. but we can disqualify people under 65 and we can qualify people over 75. There's no doubt. But I would say that it's less restrictive with CAR T. So if someone was not eligible for autologous stem cell transplant, they still may be eligible for CAR T.
Cool. And along with that, I mean, I know that you're very familiar with the Canadian landscape as well, although you do practice in the US right now. The question is CAR T free in Canada, or is it reimbursed in Canada? And I don't know if you want to answer that, or if you want me to answer it, or.
Yeah, well, you can answer the formal reimbursement part. The reality is you know, for Canada, it's got to be approved first by Health Canada, right? You know, the Canadian version of the FDA, before it then goes through the very complicated, which keeps changing its name, process of getting approval for funding. So it's not yet approved by Health Canada for its use. So any CAR Ts that would be done now for myeloma in Canada would be under the context of a clinical trial. And in those trials, generally speaking, of course, patients aren't charged for that trial. But in terms of general reimbursement, that hasn't happened yet because, of course, it's not yet Health Canada approved. I don't know if you have more to add to that.
Yes, there is the ide-cel, which was Health Canada approved. However, it is not. It won't be reimbursed. It was recommended against that. So right now, for that particular one that was Health Canada approved, it's not available. Perhaps there will be another one that will come in the future, such as the one that you spoke about earlier. So we're monitoring that situation, and hopefully it'll be available at some point. But right now, it's just not available, other than in the clinical trial setting. Another thing that's also not available, mass spectrometry in Canada. That's the question. So is it available in Canada? My understanding is that it's still something that's done under a research protocol and not available to the general public.
Correct, and it's really actually not very available here in the US yet. I mean, Mayo Clinic, where I used to work, have a protocol where they're incorporating it into their, myeloma clinic, as it were. There's a move towards bringing this to the FDA as a legitimate way of, ultimately replacing how we measure the proteins in the blood. I mean, for those who aren't as familiar, this is like the most sophisticated way of looking at all proteins in the blood. If you saw how in the lab we generate an M spike, you'd realize it's still relatively crude, to be blunt. And so I definitely think this is the way of the future. I think it's going to come to Canada as well, for sure. But a lot of details need to be sorted out. It's not a simple test. Ultimately, to be honest, it's actually going to be cheaper to do it this way, because even though the testing, the machine itself is rather costly, it can generate the result within minutes. So this idea of, always you having to go a few days, if not a whole week before your visit, wait for us in the lab to do the serum protein electrophoresis and all the other tests, that may be able to change. We may be able to change that parameter. And it's much more precise. As some of you have learned, when you're on a drug like daratumumab or isatuximab, that itself can show up like an abnormal protein in the blood. And so it can skew what we're thinking. With mass spec, we can identify, oh, that's the daratumumab spike, that's the isatuximab spike, that's the patient's own M spike.
You're bringing me back to school now.
Yeah,
remember running those gels. So we have 2 minutes left. Do you have a hard stop at 4? Can we stay an extra 2 minutes, or?
We can stay an extra few minutes. Absolutely.
Okay, cool. So I'll go on to the next question.
Anything for my Canadian homies, I'm good.
We appreciate it. We love you. So translocation 414, are there any studies that are specific to that translocation?
So as we know in myeloma, there are we call it multiple myeloma. Actually, the word multiple is good because really there's different myelomas. There's a really nice paper published a few years ago called The Multiple Myelomas, showing that myeloma is not really one disease. And so we can divide myeloma in different categories and buckets. One of the way we do it is by these so-called translocations, which just means that one piece of a chromosome from one chromosome and a piece from a different chromosome get together. They're normally not together, but they have a date. And sometimes it's a permanent date. And so we see translocation 414 means a piece of chromosome 4 and a piece of chromosome 14 come together, or translocation 1114, a piece of 11 and 14 come together. We're learning a lot about the pathways of those two specific translocations. For 414, right now we don't have a specific treatment. There have been a few drugs that have been tested that haven't, in fact, I remember even doing one when I was still back in Princess Margaret, that didn't really come to fruition. They didn't really seem to have that much of an activity, but there are others that are studying it. For translocation 1114, the answer is yes. We actually feel, and it's not yet FDA approved, it's being pursued, but there is a drug, because we've learned when translocation 1114 happens, there's a pathway we call the BCL2 pathway that is kind of upregulated, that is supercharged. And so we've developed a drug that can kind of turn that volume down, a drug called venetoclax, that ironically we use in other diseases like leukemia. And that seems to be effective. But whoever asked the question, bravo and thank you, because it's helping us see that myeloma is different diseases in one. And hopefully with time, we can be more precise in our treatments of those different types of myeloma.
Thank you. So a quick one before I move on to the next one. So CRISPR. We didn't talk about it. So someone's asking a little bit about it, and essentially, I can tell you that it's not available in Canada, but what's the situation in the US when it comes to CRISPR?
Yeah, I mean, it's still a research platform, right? I mean, I think there was a few years ago this sort of super excitement of CRISPR. Everybody thought CRISPR is going to change the world, you know, that we're going to be able to go in and change everybody's genes and reverse malignancy and reverse chronic disease and other things. I mean, I'm not poo-pooing it by any means or trying to dissuade our excitement around it, but and there has been some very good work in CRISPR. In fact, at one of our International Myeloma Working Group summits a few years ago, our keynote lecture was on CRISPR. So I think there's some fascinating work there. I think it's just a little bit early to start thinking about how it's going to directly affect patients. But you know, I go back to one of the points I made during the talk, which is if I'm going to defeat this enemy, I need to understand it. And some of the principles that we're learning through CRISPR is appreciating, you know, the complexity of the genetics of myeloma. There's certain diseases where maybe a little bit more straightforward to use that technology, where there's really one major chromosomal challenge or problem. Myeloma, we're learning, is so many different things. You know, I kind of tell people it's even cancer is kind of like the economy, right? There's so many different moving parts to it. You can't fix the economy overnight by just affecting unemployment or the GDP or the interest rates, or, you know, I mean, I'm not a financial expert by any means. That's about the extent of what I know, but you know, it's such a complicated network. And I think we're seeing that similarly with myeloma. And I think that's what's going to we're going to have to take a lot more time to really incorporate CRISPR into our approach to treating patients.
Great. Next one. Can you tell us a little bit about induction therapies and the difference, or are there any studies that show a difference between something like RVD that's mostly used in the US, or something like CyBorD that's used mostly in Canada as a frontline treatment before transplant?
Yeah, great question, and a study under a question that's under great investigation. I think the way I can summarize so many of the different studies that have been is, obviously, the best induction therapy is what you have available to you, right? I mean, we have to be realistic. So much of my work now at the IMF is directed towards trying to better access treatments for patients all around the world. And I know at times in Canada, it's particularly frustrating because we have had studies that have really tried to do head-to-head comparisons between, you know, CyBorD and even VTD using thalidomide. And now, of course, using VRD or even KRD. I think, to summarize, when we can use both a proteasome inhibitor and an immunomodulatory drug, so typically bortezomib and lenalidomide, but sometimes it's carfilzomib and occasionally it's thalidomide, that does seem to be better than not being able to use those two together. In patients who aren't going to transplant, we have shown that daratumumab with lenalidomide is extremely effective and has actually become the new standard. The question is going to be, as I showed in the talk, is 4 better than 3? Meaning, can we use all 3 categories of drugs plus the dexamethasone? Meaning, we give the daratumumab and the Velcade and the Revlimid with dexamethasone, and that does seem to be the new standard, as I mentioned, whether it's DVRD or ISA-VRD or DARA-KRD or ISA-KRD, all 4 combinations seem to be the best. In patients who aren't going to transplant, it may be harder to give them all 4, and we may have to really have a new dose adjusting strategy or just stick with 3. We're still sorting that out. So in summary, yes, I do think we have ways better than CyBorD, but we also have to recognize what's available. For many patients, they're going to do very well with CyBorD. And if they don't, then we have the options to so-called salvage with other things. Although, generally speaking, we're not trying to save treatments in myeloma. I joke and say, you know, saving the best for last is great for a Hallmark movie, but really not for myeloma. We want to incorporate these agents earlier on.
Fantastic. And so I don't want to take any more of your time, so I'll ask you the last question. It's a very hopeful question, and then we will end it there. So what should we in Canada be most excited about?
I would be most excited about this whole wave of new immunotherapies, both CAR T and bispecifics. Even if there's been this challenge with the reimbursement so far with CAR T in Canada, I wouldn't lose hope on that, because we're trying to demonstrate that not only that one and done approach, but for the time that people stay in remission, that upfront investment. It's like buying a more expensive car because you want to get the hybrid or the electric car, maybe a bit more expensive upfront, but in the long term it's worth it. But also, if it's not just CAR T, I think these bispecifics are going to play a huge role. The fact that there's so many of them, we actually hope that may even affect the economy of scales, as it were, and reduce the cost. But I would be excited about that, because we are seeing, as I mentioned, doubling, if not tripling, of historical response rates and having it last longer. And I think as we bring these earlier in the disease course, we're going to see patients do even better. Because my objective is, as I said from the very start, is to develop a plan where I can get people off treatment. That's the way towards cure. Cure, I mean, we haven't cured diabetes. We haven't cured high blood pressure. We just control them in the long term. That's a good step. But I want to reach to a cure where we can actually say, after this many years of treatment, this person's off everything and they're genuinely cured. And I'm not saying it's in our grasp right now, but it's definitely in our sights.
And we hope for the same thing, that's for sure. So with that, there's a few more questions, but I can get back to these people with these questions. So thank you very much, Dr. Mikhael, for donating your time to us today. It was great. The recording's going to be on YouTube. Everyone's going to be able to see you like they do with the IMF. So thank you so much. Have a great rest of your evening, and we hope to have you again in the future.
Absolutely. You know, I'd be more than happy to come back anytime, my friend. Thank you so much, and my best to all those who are listening. Thanks again for giving us your time.
Thank you. Take care.